Hi, good morning, everyone. This is your Dr. Bharat Kumar V D. Welcome to the second part of one last revision of pharmacology. Yesterday, we are done with GET Pharma, ANS, General Pharma, Renal, and CVS Pharma. So, in this session, we'll be doing with the other part. Okay. So, before I move in, let me check the audio video is fine and you will be able to receive the messages properly. Right. So yesterday, I think INSCT results have come, and best wishes for those who got the top rank, and those who didn't make it, no problem. You have another opportunity of NEET PG. So there is lesser days remaining for that. Concentrate on this. So with that, we will start our discussion with the remaining topics. Okay. Now, this is the Telegram group. You can scan. There you will get the PDF. So here you just interact, try to answer the things, and the annotated PDF you will get in the end. So this is the Instagram. You can follow for any updates in pharma. Okay. So with that introduction, let me start with the question MCQ. Which of the following drug used in pulmonary hypertension acts by blocking endothelin receptor? Now, any drug which blocks endothelin receptor ends with entan. So the name is bosentan. This is the answer for this. So we have bosentan, macitentan, ambrisentan. They are used for pulmonary hypertension. Sildenafil and a drug called tadalafil. You know that they are phosphodiesterase 5 inhibitors. They are used for erectile dysfunction, but they are also used for pulmonary hypertension. Nifedipine is a CCB, also used in pulmonary hypertension. Riociguat, guat means it's a guanyl cyclase agonist. Then we have selexipag. It is a prostacyclin receptor agonist. It's a prostacyclin receptor agonist. And we have epoprostinol. These are all prostaglandins. Epoprostinol, treprostinil, iloprost. These are all PGI2. And inhaled nitric oxide is used for pulmonary hypertension in newborn. So all these options what we have written, they are all for pulmonary hypertension management. So recently they had asked inhaled nitric oxide. Where to use it? It is used in pulmonary hypertension in newborn. Okay. So that is about pulmonary hypertension. Coming to guess the drug. Yesterday we have left some of the concept of adverse effect in CVS. So try to guess the drug. Which CVS drug causes gum hyperplasia, pedal edema, and constipation? So gum hyperplasia, pedal edema, and constipation is done by calcium channel blockers, CCBs. A very typical adverse effect. What are the other two drugs which cause gum hyperplasia? We have an anti-epileptic commonly causing that is phenytoin. We have an immunosuppressant drug and that is called cyclosporin. The name is cyclosporin. Now, which CVS drug will cause headache, tachycardia? If you use it, it will develop tolerance. Patient will have flushing and constipation. They are anti-anginal drugs. The name is nitrates. These are nitrates. So when you give nitrate, patient will suffer with headache, tachycardia, tolerance, flushing, and constipation. Now this is a classical question, a drug-induced lupus. So when we give these type of drugs, patient will develop SLE-like symptoms like mala rash, joint pain, positive anti-nuclear antibodies. But when you stop the drug, it is gone. So the drugs which cause that are SHIP drugs. What are SHIP drugs? Sulfonamide, hydralazine, isoniazid, procainamide. And most commonly it is seen with two important drugs, H for hydralazine, P for procainamide. So that is about the adverse effect which can be asked in your in your NEET PG exams. Now let us move on to Autacoids. Even the topic is very small, but even one question will vary the ranks like anything. Now let us start. Sumatriptan. We know that sumatriptan is the drug of choice for two types of headache. That is attack of migraine. It is used in migraine attack. Second, it is also used in cluster headache. Cluster headache. But what is the mechanism of action of sumatriptan? It's a 5-HT 1B 1D agonist. The sumatriptan is a serotonin agonist. Not only that, it also decreases nausea vomiting, it also decreases calcitonin G-related peptide. Then you can see a drug by the name buspirone. If you see the snake bus, you will have anxiety. So buspirone is used for anxiety. The mechanism is it's a 5-HT 1A partial agonist. And where do you use buspirone? We use buspirone in chronic anxiety. Don't confuse buspirone with a drug by the name bupropion. Bupropion is an atypical antidepressant which is used for smoking cessation. Most of you confuse that, avoid it. Now tell me, what is the atypical antipsychotics clozapine work like? They are 5-HT2 antagonist. Clozapine, olanzapine, risperidone, these are all 5-HT2 antagonists. Any drug ending with cetron, this is 5-HT3 antagonist. Cisapride, mozapride, procalopride, tagacid, these are 5-HT4 agonist. So they can ask you the mechanisms. I told you what is the question asked about cisapride. It can cause QT prolongation and it is already been banned. NSAIDs, non-steroidal anti-inflammatory drug, what do they inhibit? They inhibit an enzyme called cyclooxygenase, COX. Cyclooxygenase, that is called COX enzyme. Now, can you tell me which drug can inhibit the enzyme LOX? Because we are revising, so we should be able to compare the mechanisms. Yes. The LOX enzyme is blocked by a drug by the name xylitol, which is used in asthma prophylaxis. Yes, Mohammed, you are right. Now coming to the question, NSAID, which is known to cause acute liver failure. We know that a drug paracetamol is a drug which causes acute liver failure if you take it overdose. And what is the toxic metabolite which comes from that? The toxic metabolite is called NAPQI. If you want to the full form, it is N-acetyl para-benzoquinoimine. And what is the antidote for that? The antidote for that is N-acetylcysteine. N-acetylcysteine is the antidote. Now the question is, why do we use N-acetylcysteine? N-acetylcysteine will replenish the glutathione. And what does glutathione do? It will reduce the levels of NAPQI and prevent hepatotoxicity. NSAID known to increase the risk of MI. Usually we give aspirin for preventing MI, but there are drugs ending with coxib. Celecoxib, rofecoxib. What do? They are shown to decrease PGI2. So PGI2 role is to stop platelet aggregation. If PGI2 decreases, the platelet aggregation increases and there is risk of MI. So you should be very careful when you prescribe coxib. Sir, what is the mechanism of aspirin? as an antiplatelet. So when we give aspirin, it inhibits the enzyme COX irreversibly. And what is not synthesized is there is decrease in thromboxane A2 synthesis, and because of that it will produce antiplatelet action, and that's why we use it in prophylaxis of MI and stroke. And aspirin, what we use is a low dose of aspirin, not high dose. We use low dose aspirin. The dose can range from 40 to 325 milligram. Even this was when tested aspirin, how it will produce antiplatelet action by decreasing thromboxane A2. Yes, Kaustub, Toludin, Rama, correct. Moving on to gout. Gout is a small topic, but questions keep on coming. Easy to score. Let us take a case. Patient is having acute gout. Drug used which acts by inhibiting neutrophil chemotaxis and microtubule polymerization. What is the drug name? The drug name is colchicine. So colchicine inhibits neutrophil chemotaxis. One of the problem with colchicine is diarrhea. Diarrhea is dose dependent because if I increase the dose of colchicine, diarrhea also increases. Second, what is the patient having acute gout? What is the NSAID used? NSAID I can use as diclofenac, indomethacin you can use. Now for acute gout, the drug of choice is NSAIDs are the drug of choice. In acute gout, what is the NSAID never given, contraindicated? It is aspirin. Why aspirin? Because aspirin itself increases uric acid and worsens the gout. So what is the NSAID not given in acute gout is aspirin. Many students ask me, can we give paracetamol? You can give paracetamol, but it won't work because paracetamol has no anti-inflammatory property. So this is about acute gout. Coming to chronic gout, what is the drug of choice for chronic gout? The name is called allopurinol. The name is allopurinol. What does it do? It inhibits the enzyme xanthine oxidase. It's a derivative of purine. But one drawback of the drug is people may develop allergy. So for them, we have another new drug. The name is called febuxostat. It is a non-purine. It also inhibits xanthine oxidase. But the drug of choice is allopurinol. So next one is which drug increase uric acid excretion in urine? They are called uricosuric drugs. Remember the name probenecid. Then sulfenpyrazone. And a new drug called lesinurad. You see the name of the drug. It lessens increased uric acid, lesinurad. Now can you tell me a ARB which increases uric acid excretion? Waiting for your answers. ARB. Yes, the ARB which reduces uric acid. Yesterday also I told you the name is losartan. Losartan lowers two things, uric acid and thromboxane A2. Very, very important. Yes, you are right. Toludin, Rama, correct. Now in gout we use enzymes. What do? They convert uric acid into allantoin. And the enzyme name is uric acid oxidase. Now humans don't have this enzyme, we have to make them. Suppose a patient is having chronic refractory gout. What is the enzyme used? The recombinant enzyme is called peg-loticase. Remember pegloticase. In pharma, anything ending with ASC is an enzyme. Streptokinase, urokinase, pegloticase. Tumor lysis syndrome. What happens in tumor lysis syndrome? There are death of so many cancer cells. Purine is released, xanthin, then uric acid. So what is the enzyme used for that? The name is called rasburicase. The name of that is rasburicase. That is about gout. Now let us move on to another question. Drug used to treat erectile dysfunction and open PDA also. So what is the purpose of this MCQ? Is to understand various prostaglandin preparations. Now the drug which is used for erectile dysfunction and open PDA is alprostadil. It's a prostaglandin E1 analog. We have misoprostol also, which is prostaglandin E1. Where do we use it? We use it in abortion, that is medical termination of pregnancy, cervical ripening, and postpartum hemorrhage. Is there any non-obstetric use of misoprostol? Yes, we use it in peptic ulcer disease. Dinoprostol, it ends with 1, but it is PGE2. That is also used for cervical priming, but recently they had asked a question whether this is used in PPH. No, it is not used in postpartum hemorrhage. Now dinoprost, carboprost, these are PGF2 alpha, and they are mainly used to manage postpartum hemorrhage cases. Toluidine, can't we use allopurinol in tumor lysis syndrome? Yes, you can also use allopurinol, but the first choice will be rasburicase, then you can give allopurinol. Then latanoprost, bimatoprost, these are PGF2 alpha, which are used in glaucoma. The TIE drugs, TIE, these three drugs, treprostinil, iloprost, epoprostinol, these are PGI2 drugs, and these are used to manage, just now I told you, a problem called pulmonary hypertension. So these are all prostaglandin preparations. How do you identify them in the exam? You see the names contain prost in the name, misoprost, alprost. You check any name, they have prost in their name. Okay, so that is about prostaglandin preparations. Coming to migraine, again a common topic. Drug of choice for acute attack of migraine are triptans. Any triptan given in the option, you can choose that. If they are not there, then you can go for ergots. But triptans are the drug of choice. I told you they are also drug of choice for cluster headache. Most common drug used for prophylaxis is our beta blocker, propranolol, the most commonly used prophylaxis. Anti-migraine drug given, patient came with low pulse and ischemia of lower limb. What is the drug which is going to do that? Low pulse and ischemia of lower limb. It is mainly ergots. So if you give ergots, ergotamine and dihydroergotamine, these are vasoconstrictors. And we know that ergots can cause gangrene, ergotism. So suppose we give ergot and patient come with vasoconstriction. What is the treatment for this? There is a vasoconstriction. What is the treatment? Vasodilation. So what is the drug which is preferred? Immediately it will work. Sodium nitroprusside. Sodium nitroprusside. Why? Because it is an IV drug, short acting, and it will dilate both artery and vein equally. So that is how we manage ergot induced vasospasms. Now coming to newer updates in migraine, because migraine is very common. CGRP antagonist used for acute attack of migraine, they end with G-PANT. G-PANT. So the names are Ubro G-PANT, Rime G-PANT. So anything ending with G-PANT, they are for attack of migraine. What is prophylaxis of migraine? They are also CGRP antagonists, but they end with MAB. MAB, erenumab, galcanezumab, fremanezumab, eptinezumab. Have to remember that the mnemonic is every girl can free a man from everything. So remember, every for erenumab, galcanezumab, freemanezumab, eptinezumab. So these are all for prophylaxis of migraine. Now please understand the problem with ergot as well as triptan is they both are vasoconstrictors. So which patient I cannot give? I cannot give them. They are not used in a patient with ischemic heart disease where the blood flow is already low. And also I cannot give if a patient BP is not controlled, that is uncontrolled hypertension. Controlled hypertension you can give, but if the BP is not controlled, then I cannot give. Suppose a patient has ischemic heart disease and she comes with acute attack of migraine, you cannot give this. So is there any drug which has come up? Yes, we have a 5HT1F agonist used for acute attack of migraine. The name is called lasmiditan. So this drug will not cause vasoconstriction, so you can use it in patients with CVS risk. That is why this will be tested in the exam. The name is called lasmiditan. Yes, Rama, you are right. So this is about migraine. So I am highlighting what are more important for your exams and where they are going to test you. Now let us take up the MCQ part. Tofacitinib is used in rheumatoid arthritis, and the drug is rheumatoid arthritis is a very common condition, comes in medicine, ortho, pharma. So they will ask you the mechanisms. Anything ending with a nib is a tyrosine kinase inhibitor, or it can be JAK inhibitor. So remember, nibs are inhibitor of Janus kinase. So what we call it as JAK. So the answer is B for this. But let me tell you what are the drugs we use for rheumatoid arthritis. The most important drug what we use in rheumatoid arthritis which inhibit dihydrofolate reductase, the name is called methotrexate. So most of the patients we start methotrexate. Not responding, we give sulfasalazine, then we can go for leflunomide. But there are certain drugs which are called biologicals which are used for rheumatoid arthritis. So we have infliximab, certolizumab, adalimumab, golimumab. So remember, these four drugs are monoclonal antibodies, except the name itself is telling you I am an exception, etanercept. So the mnemonic is Ice Age. But if you don't remember, make a song. Infli, Sertoli, Adali, Goli, etanercept. So what do they target? They target TNF alpha. So they are TNF alpha antagonist. But remember one thing, before starting them, you have to rule out hepatitis B and TB. Because if you suppress TNF alpha, the infection may increase. And also certain cancers may increase if you give this. Then rituximab, Rohit, T20. The rituximab is CD20 blocker. Tocilizumab and sarilumab. Tocilizumab and sarilumab, they are, yes, you answer this. Abatacept and belatacept, they are blockers of CD80/86. That is co-stimulation inhibitors. Tofacitinib and baricitinib, they are JAK inhibitors, Janus kinase inhibitors. Yes, Any guesses for tocilizumab and sarilumab? What do they block? Take a guess. They are interleukin 6 antagonist. Interleukin 6 antagonist. Yes, very good. It's okay. Tried best. Interleukin 6. Remember the mnemonic S6T tocilizumab. So 6T, 6 sarilumab and tocilizumab, because they keep on asking these targets. Now coming to immunosuppressant drugs, match the following. So again they will ask you the mechanism, so that's why we made a match the following question. Number 1, calcineurin inhibitors. The calcium inhibitors are cyclosporin and tacrolimus, which are used as immunosuppressant. So I am matching 1-1. Second, we have mTOR, mammalian target of rapamycin inhibitor. The name is called sirolimus. Anything ending with limus, usually they are mTOR inhibitors. They are used for cancers, and sirolimus is also used for the stents, to prevent stent thrombosis or stent blockage. Number 3, interleukin 2 or CD25 antagonist. We use the drugs basiliximab and daclizumab. Sir, will they ask you this questions in NEET PG? Yes, this third option what I am reading, that was in 2018. Number 4, what is the immunosuppressant which causes gum hyperplasia and hirsutism? I told you. The name is called cyclosporin. Then number 5, which inhibits dihydroorotate dehydrogenase. It is nothing but leflunomide. Number 6, inhibiting IMP dehydrogenase. The name is called mycophenol mofetil. So this table will give you the mechanisms at one place. What are more important? So rather than reading pharma, what is most important? Please study and go. Even though you study 100% pharma, I can write and give. There are still 1 or 2 questions you can't solve wherever you have studied from, because the exam will prepare the paper like that. But whatever is already been known, repeated, that thing you should not make a mistake. So let us play a 50-50 match. 50-50 means there are 2 options, because in the exam what happens, we have 4 options A, B, C, D. We are able to rule out 2, but we are stuck with A and B. So let us see the logic here and answer these questions. A driver has allergic rhinitis and you want to prescribe antihistamine. So will you prescribe phenyramine or fexofenadine? Driver requires alertness while driving. So I have to give an antihistamine which doesn't cross blood-brain barrier. That is 2nd generation antihistamine I will prefer. Why not phenyramine? It's a 1st generation antihistamine which crosses blood-brain barrier and causes sedation. And you know, if a driver sleeps while driving, he will make others to sleep permanently. That's why. Now, there is a patient who has anterior uveitis. Itis means inflammation, and glaucoma. Then what is the preferred one? Latanoprost or timolol? I can't give prostaglandins because prostaglandins are inflammatory mediators and uveitis is there. I can't give. So what should I give? I can give beta blocker, timolol. A patient is having kidney disease and he has to be given painkiller, analgesic. So will he give paracetamol or will he give diclofenac? I will give paracetamol because it's not going to cause analgesic nephropathy. But diclofenac I don't want to give because it is known to produce analgesic nephropathy. The safest analgesic NSAID in CKD patients are paracetamol. Tell me, is there any other name for paracetamol? It is also called as acetaminophen. Biliary colic, I have asked you plenty of times. I will prefer pethidine. Morphine I don't want to give. Suppose a patient has liver disease and you want to give benzodiazepine. Will you give lorazepam or diazepam? I will prefer lorazepam because lorazepam will not produce active metabolite. But if I give diazepam, the diazepam becomes longer acting in liver disease. So what are the benzodiazepines safe in chronic liver disease patient? The mnemonic is LOT. L for lorazepam, O for oxazepam, T for temazepam. These three benzodiazepines are safe in liver disease or patients having chronic alcoholism. Right? Yes, Mohammed, you're right. Rama, you're right. Very good. So I hope you understood the reasons for this, why we are choosing it. So let us take up some more 50-50. Patient is having 2 to 3 episodes of loose stool, no fever. Will you prefer ORS or will you start oral antibiotics immediately? I will start ORS. It can be a mild condition, so give ORS. That is enough. Immunity will fight. Patient is not having fever. Then why you want to give simply antibiotics? Now, if you want to close PDA, will you give alprostadil or indomethacin? Indomethacin, because it closes. Alprostadil opens it. Parkinson disease patient starts having vomiting. Will you give domperidone or will you give metoclopramide? I will give domperidone because metoclopramide crosses blood-brain barrier and it blocks D2. What is the problem? Already is a Parkinson disease patient. If you block dopamine in the brain, the symptoms worsen. So what should I give? Domperidone because it doesn't cross blood-brain barrier. That's why. Next, a 5-year-old child has viral fever. So a child come to you, it has viral fever and you have to reduce the fever. Will you give paracetamol or aspirin? So remember to give acetaminophen. Never give aspirin because if you give aspirin in less than 12-year-old child with viral fever, it can lead to a problem called Ray's syndrome. Patient may develop Ray's syndrome. Very, very important. Ray's syndrome. What happens in Ray's syndrome? There is damage to the brain, damage to the liver. Again, peripheral vascular disease, the drug of choice are CCBs. You can also give nitrate, but preferred is CCB. Acute gout, I will prefer diclofenac. I don't give aspirin. You know the reason for that. Thyroid storm. Suppose you are doing a thyroid surgery and there was thyroid storm. The body temperature goes up. High body temperature. Will you give paracetamol or will you give aspirin? This you answer, guys. I will be waiting for your answer. Yes, I will go for paracetamol. Why not aspirin? Aspirin is known to displace thyroxine. Now, what happens if you displace T3, T4? Their level free form will become more and it will worsen the thyroid storm. So, better to give paracetamol. Why not aspirin is also the question, right? Because it displaces T3, T4 from binding and increase their free level and it will worsen the condition. Now, we are done with 50-50 and that is how we can exclude some of the questions and come to the right answers. Coming to drug interactions, we have a combination of imipenem plus cilastatin. Is it rational? Yes. Imipenem is a carbapenem which is short acting because it is metabolized in the kidney by an enzyme called renal dehydropeptidase. So if I add cilastatin, it inhibits renal dehydropeptidase and makes the imipenem longer acting. So imipenem becomes longer acting and also reduce the nephrotoxicity. So right, you can give it. Amoxicillin plus clavulanic acid, yes, you can give it because clavulanic acid is a beta-lactamase inhibitor. So any bacteria producing beta-lactamase, you can give it. Can I give erythromycin plus theophylline? No. Erythromycin is an enzyme inhibitor. So if I give with theophylline, the theophylline toxicity will happen. I gave the same question earlier. Anna, yes, we will be taking a separate session for FMG, don't worry. So can I give phenytoin and sucralfate together? No, because if a patient takes sucralfate and take phenytoin, phenytoin will not get absorbed. So there is decreased phenytoin absorption. There is decrease in phenytoin absorption. So if you want to give them together, you have to give 2 hours gap. So I am ticking which is right and which is not right. And I am giving you the reasons. Okay. So methotrexate plus folinic acid, yes. So when you are giving methotrexate, it will also affect the normal cells. To rescue the normal cells, I give folinic acid, right combination. Can I give verapamil and metoprolol? No. Both are cardiodepressant. If I give them, patient will have severe bradycardia, severe heart block. So never give them together. Can I give nifedipine with metoprolol? Yes. Nifedipine is a CCB which can increase the heart rate, tachycardia. Metoprolol is a beta blocker which decreases heart rate, so they will compensate each other. I can give them. So the last one will be, can we give alcohol and metronidazole? We are not going to give alcohol metronidazole together to any patient. Suppose patient had amoebic dysentery, is taking metronidazole and he goes and drink alcohol, then what will happen? So this will lead to disulfiram like reaction. So nidazoles, anti-protozoal drugs, you should be careful. Okay, sir. So I hope you got these drug interactions, because this is how the questions are framed nowadays and asked in your exams. So with that, we are done with the Autacoids. Let us move on to another major topic, antimicrobials. Antimicrobials, first thing I need to understand is mechanism of action, how they work. So the question is, which of the following act by inhibiting cell wall synthesis? So the drugs which inhibit cell wall synthesis are beta-lactams, in this example, cephalosporins. The answer is B, cephalosporins. But the question is, what about erythromycin, chloramphenicol, sulfonamide? Let us analyze that. So any drug can act on either cell wall, cell membrane, DNA, RNA, protein, like that. So what are the major drugs which inhibit cell wall synthesis? Beta-lactam and GPs. GPs means glycopeptide. The major one is vancomycin. What are beta-lactams? They are nothing but penicillin, cephalosporin, monobactam, carbapenems. Beta-lactams inhibit a step. They inhibit transpeptidase. Vancomycin inhibit transglycosylase. They inhibit transglycosylase. Acting on cell membrane, they are polymyxin B and E. E is nothing but colistin. E is also called as colistin, and a drug called daptomycin. Inhibiting of protein synthesis, There are two ribosomes, 30S and 50S. What will bind to 30S? The mnemonic is TEAM. TE stands for tetracycline. AM stands for aminoglycosides. TEAM. 50S, we have the MCQ drugs. M for macrolides. C for clindamycin. And Q plus D, quinaprestin plus dalfaprestin. Then we have a drug called chloramphenicol and linezolid. Now linezolid binds to 23S fraction of 50S. So you have the idea where these drugs work. So cell wall, cell membrane, protein. So let us see the DNA. Competes with PABA in folic acid synthesis, inhibit folic acid synthase. They are nothing but sulfonamides, PAS, and a drug used in leprosy, Dapsone. The drugs inhibiting dihydrofolate reductase, the mnemonic is PMT. What is P? Proguanil and pyrimethamine. M for methotrexate. T for trimethoprim. Then the one which inhibit DNA gyrase and topoisomerase 4, it is nothing but fluoroquinolones, which they end with floxacin. Ciprofloxacin, levofloxacin, moxifloxacin. The one which inhibit DNA dependent RNA polymerase, the rifampicin, anti-TB drug, rifampicin inhibit DNA dependent RNA polymerase. So take your time, analyze this. Okay, so we understood the mechanism. The next thing you need to understand is which of these drugs are cidal and static. Most of the students ask me this question. Cidal. Yes, Rama, you are right. RNA-dependent RNA polymerase, it is remdesivir and ribavirin. So the cidal drugs, remember, mainly the drug acting on cell wall, the drug acting on cell membrane, they are all cidal. The drug acting on DNA gyrase, they are all cidal. But in protein synthesis, we have only one cidal, that is aminoglycoside. Sulfonamides are static, but the combination called co-trimoxazole is cidal. So if you know the cidal drugs, then the remaining is static. So drugs acting on cell wall, cell membrane, DNA gyrase, aminoglycoside and co-triamoxole, these are cidal. Remaining all are static. So you will answer one question like that. Now coming to the next question, MCQ. Which of the following antibiotics can cause bilirubin displacement and lead to kernicterus in newborn? So if I give it in newborn, they can displace bilirubin and cause jaundice leading to kernicterus. And the drugs are sulfonamides. The answer is B. Sulfonamides can also exaggerate acute intermittent porphyrias, AIP. They can exaggerate acute intermittent porphyrias. Chloramphenicol, it can cause gray baby syndrome if you give it in premature children, premature baby. Tetracycline can lead to tetracycline can lead to damage to the teeth. The teeth may become discolored and bone damage. So all these three drugs are not given in children's. What is the safest one is amoxicillin is safe. But the question is asking which will cause bilirubin displacement. It is sulfamethoxazole. That is sulfonamides. Now what I have done is I have done adverse effect at one point and you have to guess the drugs. Now tell me which group of drugs can cause hypersensitivity allergy. Most common, they are beta lactams. Beta lactams are common. Not only beta lactams, most of the antibiotics can cause allergy, but common is beta lactams. Then sulfonamides can do that. Then fluoroquinolones are commonly associated with hypersensitivity. Particularly beta lactams are known with anaphylaxis. That's why we have to give test dose. Next, Zahrich-Alzheimer reaction is seen with penicillin. So when we use penicillin to treat syphilis, what happens? The syphilis, Treponema pallidum are destroyed, and the destroyed parts, the body will mount an immune response, that is Zahrich-Alzheimer reaction. It's not an anaphylactic reaction. It's an inflammatory response. You can give NSAID or steroids. Now, which drugs can cause disulfiram-like reaction, bleeding risk, and reduce prothrombin? The names are all cephalosporins. Cefamandole, cefotitan, cefoperazone. Why only these three? Because they contain a structure that is called N-methyl thiotetrosol. They contain NMT, N-methyl thiotetrosol. Now tell me which antibiotic will cause tendon rupture, cartilage damage, and seizures. Yes, you should answer this. Yes, this is done by fluoroquinolones, that is fluoxetins. Redman syndrome, ototoxicity and nephrotoxicity. Yes, you know it is caused by vancomycin group of drugs. Allergy, Stevenson syndrome, crystalluria and bilirubin displacement. Just now I told you sulfonamides. So you have studied the note. This will help you to identify the adverse effect and come to the right answers from this. Okay. Okay, if you are done with this, let us go with other adverse effect. Ototoxicity, nephrotoxicity and neuromuscular block. Particular neuromuscular block that is done by AGs. AGs means aminoglycosides. Yesterday I told you about QT prolongation. What drugs can do that? The fluoroquinolones, the macrolides, and two anti-TB drugs. Can you tell me? Bedaquiline, pritomanid, delamanid. MAO inhibition, bone marrow suppression leading to thrombocytopenia. It is mainly linezolid. Linezolid will be tested because it's a drug nowadays for drug-resistant TB, and linezolid is also going to cause peripheral neuropathy. Peripheral neuropathy. And how do you manage that? We give B6 to manage peripheral neuropathy. The teeth damage, bone damage, vestibular damage, and diabetes insipidus photosensitivity, it is mainly by our tetracyclines. Bone marrow suppression, I just told you one drug already. The name is called linezolid, and one more drug, chloramphenicol. Any HIV drug you know which cause bone marrow depression? Yes, the name is called zidovudin. So these are the adverse effect, and we know which drugs are going to cause that because they have asked like this. That's why we made a table which will tell you everything at one point of time, one place. Now coming to adverse effects, seizures. What drugs can cause seizures? I told you yesterday, fluoroquinolones, metronidazole at higher dose, isoniazid, TB drug, cycloserine, beta-lactams, all these beta-lactams, penicillin, cephalosporin, carbapenem, particularly high risk is seen with imipenem. This was your NEET PG question. Which penems cause highest risk of seizure was asked. Penicillin, particularly procaine penicillin, increase the risk of seizures. Isoniazid and cycloserine, they are anti-TB drug known for seizures. Cycloserine is also called as psychserine because cycloserine causes psychosis, seizures. That's why. Now they have also tested hypothyroidism is caused by ethionamide and PAS. These are anti-TB drugs. Then blurring of vision, corneal opacity, and bullseye maculopathy. Tell me which drug? Blurring of vision, corneal opacity, bullseye maculopathy, and also skin and mucous membrane pigmentation. Yes, which drug? The drug name is chloroquine. Chloroquine. So I call chloroquine as color queen because it causes pigmentation. The name is chloroquine. So these are the adverse effect and antibacterial drugs. Yes, Rama, you're right. Now let's move on to the next question. 24-year-old pregnant female came to the clinic with fever, frequency, and urgency. She was diagnosed with UTI. Which of the following medications should be avoided in treating her UTI? So remember in your exams, if they give female patient, check whether she is pregnant in the question. So most of the times they will trick you there. So pregnancy, what is not at all given is amikacin. Yesterday I told you amikacin belongs to aminoglycoside. They are known to produce oral toxicity in the newborn, that is fetus. So that's why I cannot give it. So now there are certain questions they come like this. Pregnant woman, conditions where you are giving a safer one. So mania and bipolar disorder, which is to be avoided, mainly avoid valproate and lithium. The safest will be you can give antipsychotics. So you should know the alternative. Any epilepsy or seizures, particularly avoid valproate and phenytoin. Yes, Lord Rama, you are right. Then what is the alternative safer one in pregnant women with seizure? LL. What is LL? Levetiracetam and lamotrigine. Hyperthyroidism in first trimester. What is the drug avoided? Carbimazole or methimazole? Then what is the alternative you can give? Propyltyrosol is preferred in first trimester of pregnancy. What do you avoid? Carbimazole, methimazole. Right. Tuberculosis, what to avoid? Avoid aminoglycoside. This is tested. What is safe? HRZD are safe. Even in HRZD, if they ask you which one you will avoid, then I will avoid Z-pyrazinamide. But most of the questions will test you to avoid amikacin. Just now I showed you the question. Antibacterial which should be avoided are F80 fat. What is F for? Fluoroquinolones. A for aminoglycosides. T for tetracyclines. What about sulfonamides? Sulfonamides can be given, but the risk is bilirubin displacement. What are the safer ones? PCM. P for penicillin, C for cephalosporin, and M for macrolides. Macrolides like azithromycin, erythromycin, clarithromycin. Anticoagulant in first trimester. What to avoid is warfarin because it can cause teratogenicity. The safest will be heparin group. Either unfractioned or low molecular heparin can be used. Yes, Rama, you are right. Hyperthyroidism in second and third trimester, you can use carbimazole, methimazole. But first trimester, you have to avoid. That's why I have written first trimester, I will avoid this. And what I give? Propyltyrosol. But in second and third trimester, the drug of choice will be carbimazole, methimazole. Okay. Okay. Now coming to drug of choices. Again, these are tricky parts. A patient came with fever, chills and rigor, viral test positive. What is the drug of choice? See, viral test positive is seen in typhoid fever, that is enteric fever. The drug of choice is ceftriaxone, which is an IV drug. If that is not there, you can give a oral drug, cefixime. But in this, there were carriers of typhoid. For them, the drug of choice will be ciprofloxacin. We give ciprofloxacin. Then case 2, patient came with cough and fever suspected to atypical bacteria. What are atypical bacteria? They are chlamydia, mycoplasma. For that, the drug of choice would be azithromycin. The drug of choice would be azithromycin. Will beta-lactams work on atypical bacteria? No. Because, for example, mycoplasma doesn't have cell wall. Then beta-lactams won't work on this mycoplasma. There was an outbreak of MRSA infection in the hospital. A drug used to eradicate nasal carriers. Drug used to eradicate nasal carriers is topical mupirocin. If that is not there, you can use bacitracin. Bacitracin. Now the question is, how do you manage MRSA? Methicillin resistant Staph aureus. The drug of choice will be vancomycin. But certain times it will also become resistant, that is called VRSA. VRSA, the drug of choice, either you can give linezolid or you can give daptomycin. So any of these two can be used. This is how we manage MRSA. Suppose there is methicillin sensitive Staph aureus, then we give anti-staphylococcal penicillins. What are those? If you know oxacillin, I can give oxacillin. You add Cl, cloxacillin, you add dicloxacillin. Or you can give a combination of amoxicillin plus clavulanic acid. So this is what we can give. So this is about Staph aureus, a very common bacteria in hospital. Case 4, patient was given clindamycin to treat anaerobic infection. After 4 days, patient developed diarrhea due to Clostridium difficile. This is called pseudomembranous colitis. Now, when we give antibiotics to treat some infection, patient will get diarrhea. Why? Because this will go and destroy the normal flora. So when you destroy the normal flora, the pathological bacteria will multiply. In this case, the Clostridium difficile is multiplying. So that is causing diarrhea. So which is the common drugs which are going to cause this? Number 1, clindamycin. Then we have cephalosporins, very commonly, particularly the 3rd generation are going to cause this. Then the aminopenicillins like ampicillin and amoxicillin, then fluoroquinolones. These are known to produce pseudomembranous colitis commonly. What is the drug of choice? The drug of choice is fidaxomicin. If fidaxomicin is not there, you can give oral vancomycin. So this is the drug of choice. Case 5. Patient came with fever, headache and neck stiffness. Brudzinski's sign positive. Kernick's positive. What is the empirical drug of choice? So it is a case of bacterial meningitis. So the drug of empirical means without knowing the infection, what I can start is ceftriaxone. Ceftriaxone is the drug of choice for, or empirical drug of choice for suspected bacterial meningitis. But remember, ceftriaxone will not work on listeria. So if it is due to listeria meningitis, the drug of choice will become ampicillin. This is not tested. Otherwise, ceftriaxone will cover maximum bacteria causing meningitis, but it will not work on listeria. For listeria meningitis, you can give ampicillin. Right. So other diseases and infection drug of choice, pertussis, diphtheria. Either we can give azithromycin or erythromycin. Rickettsia and leptospirosis, I can give doxycycline. Same drug, doxycycline here. Enterococcus faecalis and listeriosis, just now I told listeria, we need to give ampicillin. Haemophilus influenza, the best drug is ceftriaxone. We have to give ceftriaxone. Okay, yes. Now let us move on to the next MCQ. Which of the following drug is given to a patient presenting with urethral discharge due to gram-negative diplococci and organism is resistant to penicillin? I think it's a INICET question, just now they have asked. Tell me, what is the gram-negative diplococci? It is gonorrhea. And nowadays they have become resistant to penicillin, not nowadays, from previous days only. So the drug of choice will be ceftriaxone. So ceftriaxone. So what are we going to discuss in this? We are going to discuss the STDs and drug of choice. Gonorrhea and chancroid, the drug of choice is ceftriaxone. Non-gonococcal urethritis, the drug of choice will be azithromycin. Syphilis, all stages, we use benzathine, penicillin. But in neurosyphilis, Benzathine penicillin cannot enter the brain. So we use aqueous penicillin G. So we use aqueous penicillin G. Chlamydia, lymphogranule venerum and granulum inguinal, we use doxycycline. If that is not there, we can use azithromycin. Trichomoniasis, where you see strawberry cervix, for the drug of choice, you all know it is metronidazole. Herpes, that is also been tested in INCT. It is acyclovir. So STDs is a question from Pharma, it's a question from Dharma, so please never miss them. So coming to tuberculosis, which of the following drugs used in TB acts by inhibiting mycobacterial ATP synthesis? So the drug is none other than bedaquiline. It inhibits mycobacterial ATP synthesis, and it is the only drug which acts on dormant TB bacilli. Right. What about the other mechanism? Isoniazid. It inhibits mycolic acid synthesis. Rifampicin, I told you, it inhibits DNA-dependent RNA polymerase. Pyrazinamide, ethambutol, not important. They don't ask you the mechanisms there. Delamanid also inhibit the cell wall synthesis. Now, what I want to communicate here is, what are the adverse effects they keep on asking for this? Isoniazid, it can produce H, hepatotoxicity, and I can remember like this. See, isoniazid is written as INH, correct? I, it is an enzyme inhibitor. N, it can cause neuropathy, that is called peripheral neuropathy. And the treatment is B6. Patient may develop hepatotoxicity. Rifampicin, remember red color. So it will cause orange-red discoloration of all the secretions like tears, saliva, sweat, urine, even contact lens. So it is not a major adverse effect, but they will ask. And also it is hepatotoxic. Pyrazinamide start with P, so it causes pain. Where, sir? In joints. Why, sir? Because it increases uric acid. It increases uric acid. So, suppose a patient is having TB and is on pyrazinamide and develops joint pain. What is the next step? Will you stop pyrazinamide? No. Give the analgesic. That's it. Ethambutol, E, it causes eye problem. Eye means it will cause retrobulbar optic neuritis. So patient will have decrease in visual acuity, red-green blindness, that is ethambutol. Bedaquiline and delamanid, I have told you, they cause QT prolongation, that is being tested. And bedaquiline is also a hepatotoxic drug. So these are the things which they keep on testing you in the exam. So isoniazid, rifampicin, pyrazinamide, ethambutol, bedaquiline, delamanid. If you want the most hepatotoxic drug is Z. Then we have isoniazid, that is H. Then the least will be R. So the most is pyrazinamide. Now isoniazid, why isoniazid develops resistance? Because isoniazid enters the bacteria. In the bacteria there is a gene called CAT-G gene. This gene codes for catalase peroxidase. And this will make the isoniazid active. So there is a gene in the bacteria which will produce catalase peroxidase. So isoniazid will become active. So the bacteria is intelligent, it has to survive. So it will mutate the CatG gene. So catalase peroxidase is not produced and isoniazid will not work. So this is the point. Then coming to the definitions of MDR-TB, XDR-TB you will study in community medicine. So there are some clarities I want to give you, because some of the drugs end with azole. Remember, if a drug ends with prazole, pantoprazole, omeprazole, it's a PPI. But if a drug ends with prazole, for example, aripiprazole, it is a atypical antipsychotic. It is a atypical antipsychotic. If a drug ends with bendazole, albendazole, it is an anti-helminth. If a drug ends with nidazole, metronidazole, it is anti-protozoal. Because many a time identifying the drug only you will make mistake. Conazole, fluconazole, luliconazole, ketoconazole, they are antifungal. Ozole, for example, letrozole, anastrozole, they are aromatase inhibitors. So this is the confusions which you may have in the exams. Even though these are minor thing, but in the exam you are tensed up with 19 subject, you may make mistakes, so avoid that. Okay. Let us take up a case. Fever for 1 week, abdominal distension, loss of appetite, not responding to antibiotics, not responding to malarial drugs, RK39 dipstick positive. Which drug can be used in the condition? First you should tell me the condition and then drug of choice. Come on. So this question is regarding visceral leishmaniasis because of RK39 dipstick positive. The drug of choice is LAMB. What is LAMB? Liposomal amphotericin B. That is the drug of choice for this. Yes, Kalas are correct. Which of the following drug is not used for clinical cure of malaria? Now, sulfadoxine, pyrimethamine, dapsone, tetracycline, clindamycin. These are slower acting drugs used for clinical cure. Artesunate, chloroquine, mefloquine, halofandrin, all these are going to work on erythrocytic stage and they can cause clinical cure, that means reduce fever. Primaquine is not going to cause clinical cure. It can act on exoerythrocytic stage, then it can act on hypnocytic stage, it can act on gametes. So it will never act on the erythrocytic stage. So that's why it will not have clinical cure. Now let us understand certain cases. What is the drug used in malaria for killing gametes? The radical cure means to kill hypnocytes and reduce relapse. The drug name is primaquine. Primaquine is given for radical cure and the radical cure is given for 14 days. But nowadays for radical cure we have a drug called tafenoquine. Tafenoquine specialty is the half-life is very long, 14 to 19 days. So if you want to give radical cure, one dose is enough with tafenoquine. Radical cure with primaquine is not done in pregnancy, true or false? True. Now, if I give in a pregnant woman primaquine, primaquine is going to cause hemolysis in the fetus, because fetus is relatively G6P deficient. So please understand, primaquine is contraindicated in pregnant. It is contraindicated in G6PD deficient patient. If I give it in G6PD deficient people, it will cause hemolysis. If I give it in pregnant, the fetus will suffer. So I don't give it. After the person leaves endemic area of malaria, the prophylaxis need to be continued for how many days? Usually when somebody goes for malaria endemic area, they have to take prophylaxis. If it is doxycycline, we start 1 to 2 days before journey and give it daily during the journey, and after coming back also they have to take it for 28 days. Suppose you are giving mefloquine, longer acting, it can be started 1 to 2 weeks and taken every week during journey. After coming also, mefloquine should be taken for 4 weeks. So this is very, very important. Then coming to the cases, a patient from northeastern state was diagnosed to have infection with falciform malaria. What is the most appropriate drug for this patient? Now, before I come to falciform malaria, how do we manage Vivax then? Plasmodium Vivax. We give chloroquine for 3 days, and then we give primaquine for 14 days, because we want a radical cure. So we give primaquine for 14 days. In the earlier NEET PG 2024, they had asked how many tablets of artesunate you will give, how many tablets of primaquine will you give. Those type of questions, it's highly impossible to answer unless you are giving those tablets every day in your hospital or you are practicing them. The only advantage is if you are in a primary health center and you are dispensing these drugs, you may know. Otherwise, it's highly difficult to answer those questions. So should I read now also? Not required. Those type of questions, again, they may not come. Now, coming to falciparum malaria, in India, falciparum will not work for chloroquine. Okay, so chloroquine resistance is seen with falciparum. Now, if the person is from northeast state, then we use a combination of artemether plus lumefantrine. Remember me for northeast. For that, we add a single dose of primaquine. Single dose. Why do we give single dose of primaquine? For killing the gametes. Why do you kill gamete? To prevent clinical transmission. Because mosquito will come and bite and take the gametes, sexual cycle, again they infect others. So why give gamete killing? We give it. This is for falciparum. Now, rest of India, patient from Rajasthan was diagnosed to have falciparum. What is the most appropriate drug? Northeast, I told you. In rest of India, we use artesunate plus sulfadoxine pyrimethamine combination. For that, I add 1 dose of primaquine. This is what we do. So rest of India, remember SU, SU. There it is me. Here it is SU, SU. Okay, so Vivax I understood, sir. Chloroquine for 3 days and primaquine for 14 days. Falciparum, northeast, me. Then rest of India as SU, SU. And a single dose of primaquine. Okay, another case, patient returned from Assam, fever with chills, delirium, seizures. So fever with chills, malaria. Diagnosed to have malaria, but what is this malaria? It's a complicated malaria because patient is having seizures. So cerebral or complicated malaria. What is the drug of choice? The drug of choice is IV artesunate. So once the patient is stabilized, then you can go for oral ACT therapy. Oral ACT means artemisinin combination therapy. First drug of choice is IV artesunate. Earlier days, you can see in the books IV quinine. But the problem with that is it is going to cause hypoglycemia and arrhythmia. So the safer one nowadays is IV artesunate. Sir, suppose this patient is pregnant and she has complicated malaria. Then what is the drug of choice? Even in pregnant complicated malaria, IV artesunate is a drug of choice. So malaria in pregnancy, will it change the treatment? Yes. Suppose she has Vivax, I can give only chloroquine for 3 days. Sir, what about radical cure? Radical cure I cannot give because she is pregnant and it is contraindicated. Primaquine is contraindicated. I will do the radical cure once she delivers the baby. Sir, what if Vivax relapses? Again, I will give chloroquine. That's it. If she is Plasmodium falciparum, then I have to give first trimester. I have to give quinine plus clindamycin. In second and third trimester, depending on the area, you can give artemisinin combination therapy. Okay, so quinine plus clindamycin in first trimester because they are safer. Second and third, you can go for ACT therapy. Now, one more thing I want to add up here. Suppose a patient comes to you, and you see in the blood both Vivax and falciparum, both are been infected. Then what is the treatment? What's the treatment? Will you give chloroquine? No, we will give ACT regimen only. But with ACT regimen, we use primaquine for 14 days. Why 14 days? Because Vivax, I have to do radical cure and kill the hypnocytes. That's why. Yes, so I think we are already 1.5 hours ahead of this session. So in between, I want to ask you, are you understanding? Is the session becoming useful for you? Are you able to revise your notes? That is the purpose. Okay, because I know I have many students from various platforms who will be watching this, and this should be beneficial to you people at the end. So put a message from your side. Okay, Manohar, thank you for that message. Coming to antiviral and the mechanism of action, first we'll take up HIV drugs. Now, first one is integrase inhibitor. Integrase inhibitors, they end with gravir, or you can remember as tegravirs, integrase. So they end with tegravir, raltegravir, dolutegravir, bictegravir, they are all integrase inhibitors. Now coming to GP41 inhibitor, glycoprotein 41 inhibitor, the name is called Enfoveritide. And CCR5 inhibitor, the name is called Malaria. And entry inhibitor, we have a recent drug called ibalizumab. Malaria. So these are the mechanisms and what are the drugs? Integrase inhibitor, Enfoveritide, Malaria, ibalizumab. Coming to the other drugs which are older, NRTI, nucleoside reverse transcriptase inhibitor. The first HIV drugs, zidovudin, didanosine, abacavir, lamivudine, emtricitabine. Now I mark these 3 drugs in red What is the specialty of marking these three in red? These three are also useful for managing hepatitis B virus. Sorry, sir. Just a minute. Not that. These three. LET, lamivudine, emtricitabine, tenofovir. These three are also used to manage hepatitis B virus. Remember the mnemonic LET, lamivudine, emtricitabine, tenofovir. They are also used for managing hepatitis B. Tenofovir is also called as NTRTA, nucleotide reverse transcriptase inhibitor. The other drugs are stavudine and zalcitabine. Then we have NNRTI. NNRTI, we have the DEN drugs. The DEN means delaviridine, efavirenz, and nevirapine. The second generation, they end with virin, rilpivirine, etravirine, doravirine. At least remember these three drugs. Then delaviridine, efavirenz, nevirapine. Then the protease inhibitor, they inhibit viral assembly, they end with navir. For example, ritonavir, lopinavir, amprinavir, tipranavir, indinavir. So they are all protease inhibitors used for HIV. Now moving on to the next adverse effect. Let us guess the drug. Bone marrow suppression, myopathy, nail pigmentation is mainly by which anti-HIV drug? Zidovudine. Now you have to tell me which anti-HIV drug cause palm and sole pigmentation, that is for you. Which will cause metabolic syndrome, that is weight gain, diabetes, low HDL, high triglyceride, that is by protease inhibitors. That means they end with navirs. Nephrolithiasis is done by indinavir. Yes, Rama, tell me. Which one will cause palm and sole pigmentation? That was the previous question. The name is called emtricitabine. Emtricitabine can cause palms and sole pigmentation, but nail pigmentation is done by zidovudine. Then bone mineral density GFR reduced by tenofovir. And this one which I am marking now, this was your NEET PG question. Palm and sole pigmentation. Okay. Yes. Now certain times HIV associated problems are also being tested in NEET PG. Suppose a patient is HIV associated lipodystrophy, what is the drug to be used? So we have growth hormone releasing hormone preparation. The name is called tesamorelin. The name is tesamorelin. HIV patient, you have to give prophylaxis for pneumocystitis cerevisiae. Then the drug what I use is cotrimoxazole. HIV patient with diarrhea due to drugs treatment, I can give either loperamide or a new drug which we discussed yesterday, a chloride channel inhibitor called crofelemer. Suppose a patient has HIV and TB co-infection, what is treated first? First you have to treat TB. After 2 weeks, you start treating HIV. Why? Because if I treat HIV first, there is immune reconstitution inflammatory syndrome, and that will affect the patient. So this is the application part. Now let us take up some MCQ here. HIV positive patient is on zidovudine, lamivudine and nevirapine for HIV. is recently diagnosed with TB. Which of the following drug is not included in TB treatment? Can you guess? I think I asked this question yesterday also, same question. So the drug what is avoided is rifampicin, because rifampicin is an enzyme inducer. So it can reduce the levels of these drugs. So be careful and try to replace with rifabutin. Coming to hepatitis C. Hepatitis C, the older drugs are ribavirin. Ribavirin, it is a RNA-dependent RNA polymerase inhibitor. Interferon alpha mechanism is unknown, but it is used for hepatitis C. But the newer drugs are NS5 inhibitor, 5B inhibitor, and protease inhibitor. 5A inhibitor end with asvir. For example, ledipasvir. It will NS5B inhibitor end with bovir, sofosbuvir, dasabavir. Then NS3 bar 5, that is protease inhibitor, they end with pravirs. So this is how you can identify them in the exam, the drug name, because NS5A there are 5 drugs, B there are more than 5 to 6 drugs, pravir there are so many drugs. Now coming to hepatitis B, what's the drug of choice? Anybody? Waiting for your answers. Hepatitis B, you should tell me the answer. The drug of choice is tenofovir. The drug of choice is tenofovir. Now coming to other virus, neuraminidase inhibitor used in influenza prophylaxis and treatment is, the name is called oseltamivir. The brand name Tamiflu. But majority of question is mechanism of oseltamivir. Drug of choice for herpes 1, herpes 2, varicella zoster is acyclovir. Cytomegalovirus, ganciclovir. But if they don't work, resistant cases, then we give a drug called foscarnet. Foscarnet is given. Then what is the drug used in RSV infection? RSV infection, earlier we used to give ribavirin. Prophylaxis, we use a drug called palivizumab. Prophylaxis, we use a drug by the name palivizumab. RSV, they don't ask you here, they will ask you in INSET pattern of exams. Now the next MCQ. HIV positive pregnant female delivered a baby. She is HIV positive, she delivered a baby. She is not taking any antiretroviral therapy. Which of the following should be started to the newborn? Zidovudine plus nevirapine for 6 weeks, zidovudine for 6 months, zidovudine, lamivudine, nevirapine for 6 months, zidovudine, stavudine, nevirapine for weeks. So let us see that. Now the problem is, a pregnant woman who is HIV positive, she may transmit it to the newborn. Let us take 2 cases here, case 1 and case 2. Here the pregnant woman, HIV positive. Here also pregnant woman, HIV positive. She is taking treatment. That means she is taking drugs. And virus load is less. No treatment, virus load high. Now the baby is delivered. Baby is delivered. So in case 1, she is HIV positive, she is taking treatment, and virus load is less, then we can give only one drug, nevirapine, for 6 weeks minimum. and then we'll check and decide what to do next. In case 2, she is not taking any drug or she doesn't know she has HIV, then only you know it. Virus load is very high. Then I don't want to take, so I have to give 2 drugs for the child, nevirapine plus zidovudine for 6 weeks. So this is what you need to understand here. So the answer comes here. She is not taking any treatment. Zidovudine plus nevirapine for 6 weeks. Yes, most of you have answered it. Now, another thing I want to put up here is the transmission, that is post-exposure prophylaxis. Because we are the medical professionals and we are going to get exposed to these type of scenarios. Suppose you are injecting a drug to HIV patient and you are putting a pen cap, not pen cap, the syringe, and the syringe picked up, needle picked you. Now what is the prophylaxis? Prophylaxis, you need to give minimum 3 drugs. And the prophylaxis has to be taken for 28 days. And within 72 hours you have to start. Don't wait for 72 hours, as early as possible. But what is the best 3 drugs you need to start is TLD. Tenofovir, lamivudine, dolutegravir should be started as early as possible, but within 72 hours. And it has to be taken for 28 days. That is post-exposure prophylaxis. Okay, that is about HIV. Mother to child transmission prevention, post-exposure prophylaxis, the drug mechanisms, everything we understood here. Moving on to the next, the antifungal drug. So you have to identify the wrongly matched antifungal mechanisms from the given option. Ketoconazole, it inhibits lanosterol 14D methylase. Yes, it is true. Okay, and flucytosine inhibits microtubule synthesis, hinders mitosis. No, flucytosine, it's going to inhibit DNA synthesis, not microtubule. Microtubules are affected by an antifungal called griseofulvin. So the second is false. Flucytosine is going to inhibit DNA synthesis. Terbinafine inhibits squalene epoxide. True. Amphotericin B increases cell membrane permeability. That is also true. So recently they had asked a question, what is the site of amphotericin B? Cell membrane is the site of action. If we are suspecting an HIV not yet confirmed, it's better to start 2 drugs. Why you want to take risk? So better to start 2 drugs. So this is the mechanisms of the antifungal drugs. Coming to drug of choice, antifungal drug of choice, let us go with this. Let us come from below. Mucormycosis and cryptococcal meningitis, the drug of choice is Mugil, what I tell you is, if you suspect, it's better to start prophylaxis. Once the report comes, if he is not HIV positive, then you can stop the treatment. So better be careful than to take the drug later. Yes or no? Suppose you take the instance, I am the doctor there. I gave an injection and after that I got a prick. I suspect he has HIV. But should I wait the report to come? So better I will start the prophylaxis, and if the report comes negative, I can stop. That's the best thing you can do. So mucormycosis and cryptococcal meningitis, the drug of choice is LAM. What is LAM? Liposomal amphotericin B. Pneumocystis cirrhosis, the drug of choice is cotrimoxazole. Then chromoblastomycosis, chromomycosis, paradococcidomycosis, the rose garden disease, histoplasmosis, the drug of choice is itraconazole. Then coming to cryptococcosis, candidiasis, coccidioidomycosis, fluconazole. So study these topics with micro, it will become easier for you. Invasive aspergillosis, it is oriconazole. Oriconazole. Sometimes what happens, patients will develop allergy to the fungus. So how do you treat allergy? Give steroids. But if you give only steroid, fungus may flare up. So add an antifungal, itraconazole. So this is how we manage the fungal infections. Mucormycosis has been tested, pneumocystitis has been tested, cryptococcal meningitis also being tested very, very frequently. I hope you are clear with this. Coming to anti-helminths. Anti-helminths, again they will ask you the drug of choice. Read with your micro. So helminths, three types: cestodes, nematodes, trematodes. For all these tinea, solium, sejanita, taper, mechnana, the drug of choice is praziquantel. Now, if there is neurocysticercosis and hydatid cyst or disease, the drug of choice becomes albendazole is preferred. Albendazole is preferred. Coming to nematodes, Ascaris lumbricoides, Ascaris lumbricoides. Yes, okay, correct. Then all these, the drug of choice is albendazole. Ankylostoma, Nicator americanus, pinworm, Trichinella spiralis. Filariasis and loba, it is DEC. What is DEC for? Diethyl carbamazine. Strongyloidosis and onchocerciasis, it is ivermectin. Ivermectin is also an oral drug for scabies. Most of the drugs for scabies are topical. Only oral drug is ivermectin. Cutaneous larva migraines also we use ivermectin. But if it is not there, I can give albendazole. Visceral larva migraines, the drug of choice will be albendazole. Coming to the last one, the flukes. For all the flukes, the drug of choice will be praziquantel. But for liver fluke, your fasciola hepatica, it is triclabendazole. Triclabendazole. Which antifungal is a long QT syndrome, Sankalpa Reddy? It is the ketoconazole. Azole antifungals, particularly ketoconazole is associated with it. So these are the drug of choices for helminths. When you study micro, you want drug of choice, you go with this. So I have tried to cover every aspect in antimicrobials. These are the most important things here. Yes. So relax for 5 minutes. We'll restart. 5-minute break. Okay, so let us start. Hope the audio video is fine. We'll start with the next one, the endocrine pharma. So endocrine pharma, most of the times we are into understanding diabetes. 44-year-old patient with type 2 diabetes, history of sulfa-allergy. He has history of medullary carcinoma of thyroid and bladder cancer in the family. He is already on metformin, but plasma glucose and HbA1c are not under control. Which drug will you add to this patient? Tricky question, but we'll understand plenty of concept here. So sulfa allergy, patient is diabetic but sulfa allergy. So which drugs I cannot give? Glimepiride I cannot give. Because glimepiride, they're all sulfonylureas. So already patient is allergic, I can't give. Now, medullary of carcinoma of thyroid history is there. So liraglutide is a GLP-1 agonist. And these are also known to increase the risk of medullary carcinoma of thyroid. This is also ruled out. Now, pioglitazone I cannot add because there are reports that pioglitazone increase the risk of bladder cancer. I cannot give. So what I can add to this patient is linagliptin. That is what I can add. So what did I understand from this MCQ? I understand the adverse effect of certain drugs. With that introduction, let us see what are the drugs in diabetes. What should I remember? So first of all, sodium and water retention, fracture in females, increased risk of bladder cancer. This is seen with the drug pioglitazone. The name is pioglitazone. Medullary carcinoma of thyroid risk is increased, that is seen with GLP-1 agonist. GLP-1 agonist, they end with either nartide, for example xanatide, or they end with glutide. Now this is very important, what you have marked in red. Glycosuria, risk of UTI, genital mycotic infection commonly asked. This is seen with SGLT2 inhibitors. And they end with gliflozin. For example, empagliflozin, canagliflozin, dapagliflozin, like that. The other rare adverse effect of these drugs are this, that is Fournier's gangrene, diabetic ketoacidosis, fractures, lower limb amputation risk. Now, what anti-diabetic drugs cause hypoglycemia? Remember, the insulin can cause it. The sulfonylureas like glimepiride, glycoside, they can do that. And the MGs, meglitinides, they end with repaglinide, nataglinide. These are the drugs which have the risk of hypoglycemia when you give it for diabetic patients. Just a minute. Now coming on to the other adverse effect, allergy. So whenever I think any drug causing allergy, they are all sulfonylureas. Now a drug causing dilution hyponatremia, hepatotoxicity and cholestatic jaundice, there is a drug sulfonylurea that is called chloropropamide, but it's an outdated drug, but sometimes the examiner can ask from that also. That's why I had to tell you. Drug causing lactic acidosis, B12 deficiency and contraindicated renal failure is our best drug for diabetes type 2, metformin. So what did we learn from this? We learned the adverse effect and what drug is responsible here. Now coming to the diabetic drugs and the impact on weight. Weight neutral, we have metformin and gliptins. That is DPP4 inhibitors. DPP4 inhibitors. Weight loss, we have SGLT2 inhibitors. GLP-1 agonist, and a drug called pramlintide. Weight gain, all the old drugs like insulin, sulfonylurea, meglitinide, pyridoxine, they cause weight gain. Now moving on to the next one, how to understand and remember diabetic drugs. Now a diabetic drug ending with gliptin, it's a DPP4 inhibitor. Any diabetic drug starting with glimepiride, glycoside, they are sulfonylureas. What do? They inhibit ATP sensitive potassium channel in beta cells. ATP sensitive potassium channel in beta cells. Even glinides, they are called meglitinides. They have the same mechanism. They also inhibit ATP sensitive potassium channels. Drugs ending with gliflozin, we know that they are SGLT2 inhibitors. Any drug ending with Bose, Oglibose, acarbose, they are alpha glucosidase inhibitor. We have another drug by the name Migliton. Any drug ending with glutide or nartide, they are GLP-1 agonist. We know it. Now, what is a PPR gamma agonist? PPR gamma agonist is pioglitazone. So we have a new drug which is a PPR alpha and gamma agonist. The name is called saroglitazar. So saroglitazar is developed in India, which can be used to manage both diabetes and dyslipidemia. If you remember, in dyslipidemia, we have fibrates. What is the mechanism of fibrates? Fibrates are PPAR alpha agonist. So they stimulate PPR and they stimulate lipoprotein lipase. But we have a drug which can do both alpha and gamma agonist, that is saroglitazar. What is the drug which inhibits hepatic gluconeogenesis? Our world famous drug, metformin. Then what about pramlintide? The name has amylin. So it's an amylin receptor agonist. Amylin receptor agonist. So if you see this table, you know the mechanisms, you know how to identify the drugs in your exams. Okay. Now coming on to the features and certain questions I asked about anti-diabetic drugs. Which diabetic drugs increase GLP-1 and GAP levels? They are DPP4 inhibitors. So DPP4, if we inhibit, GLP-1 and GAP levels go up. What is the diabetic drug approved for obesity? Liraglutide and semaglutide. So if you want to become lean, liraglutide. If you want to become slim, semaglutide. But recently we have another drug called tirzepatide. So these are the drugs. What is the DP4 inhibitor safe in renal failure? The name also starts with L, linagliptin. The name is linagliptin. Now SGLT2 inhibitors, they cannot be used in renal failure, but what is the one which can be used up to 20 ml per minute per 1.73 meter square? That name is empagliflozin. GLP-1 and GAP agonist, recently approved drug tirzepatide. It's the GLP-1 and GAP. What is GAP? Glucose dependent insulinotropic polypeptide. So remember tirzepatide, I am repeatedly telling you, TIR3. It is used for diabetes, obesity and obstructive sleep apnea. So tirzepatide is the drug. Now moving on to diabetic complications. What are drugs we use? Suppose patient has neuropathy, then we give pregabalin, gabapentin, a old drug called epleristat, which inhibits aldose reductase. Suppose they develop retinopathy, we use bevacizumab and ranibizumab. They block vascular endothelial growth factor. If patient develops gastroparesis, we use erythromycin. It's not officially approved, it is off-label because erythromycin stimulates botulinum receptor in the gut. Avoid giving, if a diabetic patient has gastroparesis, don't give GLP-1 agonist and pramlintide because they slow gastric emptying. If a diabetic patient develops diarrhea, clonidine can help. Suppose a diabetic patient develops dysautonomia, suddenly hypotension, post-hypotension, we use two drugs, midodrine and doxidopa. These are prodrugs, these are alpha-1 agonist. So midodrine and doxidopa are approved for what? They are approved for postural hypertension. Now coming to reduce the risk of kidney and heart complications, CKD diabetic patients, we have a new drug called finerenone. The name is finerenone. You know spironolactone, epinephrine, similar to that we have finerenone. Now coming to the next one, insulin specialties. Now the lispro asparglolizin, what is the specialty? These are ultra short acting insulin. And their onset is rapid, so they are called rapid acting insulin. Regular insulin is called short acting insulin, not ultra short acting, short acting. But the specialty is you can give the drug IV in emergencies. Most of the insulins are given by subcutaneous, but regular insulin can be given IV as well as subcutaneous. NPH and lente insulins are called intermediate acting insulin. Intermediate. Glargine, detemmer, degludec. Glargine, detemmer, they work for 24 hours. 24 hours. So degludec, ulta, 42 hours, longest acting. These are long acting, they are called basal or peakless insulins. Peakless. So these are the various insulin preparations we have. Most of the insulins are given by subcutaneous route. Now, what is the insulin given IV in emergencies are regular insulin. What is the inhaled insulin given? The name is called Afrezza. But when you give Afrezza inhalation, you should rule out COPD, lung cancer because it increases the cough in them. What does insulin cause when you give? It can cause hypoglycemia. It can cause hypokalemia. That's why in hyperkalemia we use insulin. Now if you give insulin repeatedly at the same site, it will lead to lipodystrophy. So these are the various insulin specialties that can be asked in the exams. Patient having diabetic kidney disease. So patient is diabetic, then the kidneys gets damaged. So what are the drugs? First choice we have ACE inhibitor ARBs, Prilsartan. The second, now recently even SGLT2 inhibitors have shown to be helpful in kidney disease. The third option is finerenone, that is also useful, but the cost is a factor. Now this is very, very important. SGLT2 inhibitors, the gliflozins. Now day by day, the gliflozins are having wide spectrum of uses. Earlier when they discovered, they were beautiful drugs for diabetes. But later when we started our trials more and more, it was shown to be beneficial in CHF, reduce the mortality. And also it was shown to be reduce the risk for coronary artery disease. And also it is useful in diabetic kidney disease because SGLT2 inhibitors, what do? They act on proximal convertible. They don't allow the absorption of sodium and glucose. Now when you lose sodium, it's like a diuretic action. When you lose glucose, it's like weight loss. You are not eating anything like that. So it's like losing the glucose. So because of those things, they are shown to be beneficial in these 4 conditions. They have tested like anything these things. So please don't forget gliflozins. Coming to other aspect, selective estrogen receptor modulator used in breast cancer and increase the risk of endometrial cancer is tamoxifen. What is the SERM used in osteoporosis? The name is called liraglutide. Did I make a mistake? Drugs, where are you? Liraglutide, what? I think there is a lag, that's why. SERM, which is used in osteoporosis, is roloxifene. What is third used in breast cancer? The name is called fulvestrant. So these are all the drugs for breast cancer and osteoporosis, roloxifene. Now coming on to aromatase inhibitors used in breast cancer, we have letrozole, then anastrozole. Then we have mestane drugs, heximestane, 4-mestane. So these are aromatase inhibitors used in breast cancer. What is the role of aromatase? Aromatase will convert testosterone to estrogen. This estrogen is going to cause breast cancer. What is selective progesterone receptor modulator? Used as emergency contraceptive up to 120 hours. Now most of the emergency contraceptives are within 72 hours, like OCPs, IP levonorgestrel, right? But there is a new drug which can be used, that is ulipristal, which can be used up to 120 hours, that is up to 5 days. In one of the NEET PG, they had asked the dose also 30 milligram. Should I remember the dose of every drug? Unless you are writing it every day, you won't be able to remember. Okay, but what is already been asked, you should be knowing. Suppose a lady comes after post-coital after 5 days. Tell me what do you suggest her? Tell me what you suggest her after 5 days. So after 5 days, the option is IUCD, intrauterine contraceptive device. Now coming to next question, 8 weeks pregnant woman comes with symptoms of hyperthyroidism, T3, T4 increased, TSH reduced. What will you give the patient? So 8 weeks means first trimester. So what I prefer is propyltyrosine. Carbimazole, methimazole are drug of choice for second and third trimester. Radioactive iodine, I don't give it in pregnant women because it's a radioactive material which can cause damage to the fetus. Yes, same thing. We have discussed that. Drug of choice for Graves' disease is carbimazole or methimazole. Now, what is the antithyroid drug which are faster acting and reduce bleeding during thyroid surgery? They are nothing but iodides. Sodium iodide, potassium iodide, Lugol's iodine. These are the fastest acting and they are also used in thyroid storm. Now, what are the drugs used during thyroid storm? Thyroid storm, we use steroids for overcoming the stress. We use beta blockers to prevent arrhythmias. And we use propyltyrosine to prevent the conversion of T4 to T3. Now there was a question in NEET PG. Patient had thyroid storm and patient is asthmatic. And patient developed atrial fibrillation. Now to manage atrial fibrillation, will he give CCB or will he give beta blocker? So please answer this NEET PG. Yes, I will prefer giving CCB, particularly verapamil or diltiazem. I don't want to give beta blocker because there is a risk of bronchoconstriction and patient may worsen up. So I don't want to give. Now, coming to drugs for acromegaly. So what are the drugs we have? We have growth hormone receptor antagonist. And the name is called pegvisomant. Then we have D2 agonist, bromocriptine, cabergoline. Then last one we have somatostatin analog, octreotide, then lanreotide, pasireotide. So these are the drugs for acromegaly. In recent exam, pegvisomant was tested. Okay. Now moving on to the next one. Longest acting phosphodiesterase 5 inhibitor is, if you don't know anything starting with T will be the longest. Tadalafil. And how they work? They increase cyclic GMP by inhibiting phosphodiesterase 5. Drug used in treatment of hyperprolactinemia, we have two options: bromocriptine or cabergoline can be used. The preferred is cabergoline because cabergoline is longer acting. But in pregnant women, I can prefer giving bromocriptine. Drug of choice for osteoporosis are bisphosphonates. They end with dronate, alendronate, zolendronate, palmidronate. Now these dronates, they inhibit osteoclast and they can be used up to 5 years. 5 years usage. More than 5 years, the problem is they increase the risk of fractures. And also these dronates can cause esophagitis. They can cause osteonecrosis of jawbone. These bisphosphonates are also drug of choice for osteolytic bone metastasis and also for hypercalcemia of malignancy. Teriparatide is a bone forming agent. Means what? It will stimulate osteoblast. But if you are using it for more than 2 years, it has shown to increase the risk of a cancer called osteosarcoma. So that is why it should be reserved for severe osteoporosis only. And if you are use it for less than 2 years. What is the monoclonal antibody against rank ligand used in osteoporosis? The name is called denosumab. Denosumab. So these are the drugs. Yes, Rama, you are right. Now, drug of choice for Bell's palsy, is it prednisolone or acyclovir? Because you will come across these options, you go for prednisolone. Even though we give acyclovir, but the major drug for Bell's palsy is prednisolone. It is mainly the inflammatory process which will affect the facial nerve. Steroids are contraindicated in ileocecal TB, Kaposi sarcoma, peptic ulcer. True or false? True. Because if I give steroids in ileocecal TB, the intestine may perforate. Kaposi sarcoma is a cancer seen in HIV. Already HIV immunity is down. Steroids will also down the immunity. Peptic ulcer, because steroids decrease prostaglandin. Less prostaglandin means more gastritis, more peptic ulcer. Second, long-term use of oral steroid, patient develop blurring of vision. The reason is, now you know the simple mnemonic GTCS. You develop glaucoma if you give steroid topically. You develop cataract if you use steroid systemically. So oral is a systemic route. Patient coming with blurring of vision, so I suspect cataract. Glaucoma if you use eye drops. And you know, in steroids, you should never abruptly stop the steroid. You should taper the doses. Preterm labor. So it is again tested. If there is a preterm labor, you are not able to stop the contractions. Now what I can do, I can make the baby mature, lung mature. So for that, I can give 4 doses of dexamethasone, 6 milligram every 12th hourly IM. The alternative option I have is 2 doses of betamethasone, 12 milligram, 24 hours apart. How to remember? The second alphabet is 2, that is B, 2 doses. The fourth alphabet D, so 4 doses. So 4 doses. So this is what we can come across. Now moving on to the next question, match the following. Identify the wrong match, not the match the following, identify the wrong match. Tadalafil, you know, phosphodiesterase 5 inhibitor used in pulmonary hypertension and erectile dysfunction. True. I have told you that already. Finasteride, what does it inhibit? It inhibits 5-alpha reductase. So what happens if I inhibit 5-alpha reductase? Testosterone will not become dihydrotestosterone. Dihydrotestosterone is more potent. Finasteride is approved in male pattern baldness and BPH. True. Finasteride is approved for male pattern baldness and BPH. True. And also it is approved for hirsutism in females. Flutamide. What is flutamide? It's an androgen receptor blockade. Remember, anything ending with lutamide, flutamide, bicalutamide, nilotamide, they're all androgen blockers used in prostate cancer. That is also true. Now coming to last option, phentolamine is used in delayed ejaculation. No, phentolamine is an alpha blocker which is used in erectile dysfunction, not in delayed ejaculation. So the false statement is D. Rama, among dexa and beta, if I have an option, I will go for betamethasone because betamethasone, I can give it within 24 hours and only 2 doses. Dexamethasone, I have to give 4 doses. It takes 36 hours. So I will go with betamethasone. But problem, practically what is happening is betamethasone's ampules you are not getting easily. So that is why what is available in the hospital is more commonly dexamethasone. That's why we give that. Efficiency or efficacy both are same. But if I am the physician or the obstetrician, I want to choose, I go choose betamethasone. If it is available, I will give it. But dexa is easily available compared to betamethasone. That's why that is the preferred. I hope you got that, Rama. Now, what is the drug which is approved for premature ejaculation? Premature ejaculation, the drug approved is dapagliflozin. Dapagliflozin. Don't confuse with duloxetine. Duloxetine is an SNRI, which is also used for stress urinary incontinence. Dapagliflozin is SSRI. Remember P for premature ejaculation. Okay. Now the question was asked, why are we using finasteride in BPH, benign prostate hyperplasia? For managing BPH, just tell you this point. Benign prostate hyperplasia, 2 important drugs we use, alpha blocker and then 5-alpha reductase inhibitor, finasteride. Now these alpha blockers are fast acting. Now these are slow acting drugs. Now what will finasteride do? Finasteride, just push it here. Finasteride, if I use it for 6 months, it reduces prostate size. So it doesn't work immediately. It takes time and reduces the prostate size. So the fast acting are alpha blockers, the slow acting are finasteride. But the best thing for BPH is surgery. But nobody will approve for surgery immediately, so I have to give the drugs for that. Okay, sir. Okay. So I'll take up anti-cancer drugs. That is about endocrine pharma. Endocrine, I told you what are the things you should be able to remember, revise everything. Coming to anti-cancer drug, most of you will leave this anti-cancer topic and go. But there are certain scoring areas in anti-cancer drug you should never miss. That I am going to tell you. Okay. So whenever we give anti-cancer drugs, there are certain common adverse effects because anti-cancer drugs will also kill the normal cell. So what happens when you use anti-cancer drug, patient may suffer with leukopenia, granulocytopenia, decrease in WBC, neutrophil. How do you manage? So we have GM-CSF analog and G-CSF analog. What's the name of the drug? The name is granulocyte monocyte stimulator. So the name is sargramostin. G-CSF is granulocyte stimulator, filgrastim. This is the point. Filgrastim. Suppose there is thrombocytopenia. Then we use interleukin 11 analog. The name is called oprelvekin. Suppose there is anemia due to cancer therapy. Then we use erythropoietin preparation. Erythropoietin preparation. It's easy to identify the drug. You take E and add poietin. Anything ending with poietin is erythropoietin, or you can give one more drug by the name darbepoietin. Now the next is early CNV and late CNV best combination. I think we have discussed that again. So let me repeat this. Cetron, pitant, and best combination is cetron plus pitant plus steroid. Dexamethasone. Now, if an anti-cancer drug induces diarrhea, it is a non-infectious diarrhea, so the best drug will be loperamide. So what I can use is loperamide, which is an opioid. If there is radiosensitization, we have a radioprotector drug. The name is amifostin. Suppose there is tumor lysis and there is hyperuricemia, so the best drug will be, fastest acting will be rasparecis. If that is not there, you can give allopurinol. You can use allopurinol. Okay. Hypercalcemia of malignancy. So the drug of choice are bisphosphonates. You can also use loop diuretic like furosemide or calcitonin. Cancer-induced thrombosis. The last one is for you guys. This is also NEET PG question. What is the drug of choice? Yes, it is low molecular weight heparin. How do you identify them? They all end with parin. Enoxaparin, dalteparin, nardeparin, they are used. Now coming to anti-cancer drug and common adverse effect, which anti-cancer drug can cause cardiotoxicity? They are anthracyclines. How they end with? They end with rubicin. Tell me one rubicin, sir. Donrobicin, doxorubicin, idarubicin. So can I prevent the cardiotoxicity? Yes, you can prevent the cardiotoxicity with a drug called dexrazoxane. It can prevent cardiotoxicity. It's an iron chelator. Iron chelator. What is the drug which causes hemorrhagic cystitis? The name is called cyclophosphamide. And that can be prevented by giving mesna. And drug of choice for hairy cell leukemia is cladribine. Cladribine. I think you studied pathology and everything. Anti-cancer drug which causes thymidine-less cancer cell death. So you remember there is a drug called 5-fluorouracil. What will it do? You know, there is deoxyuridine monophosphate will become deoxythymidine monophosphate. This is inhibited by 5-fluorouracil. So if you inhibit this, the thymidine will not get synthesized. And then without thymidine, the DNA, RNA cannot be formed and the cells will not be able to multiply. The name is 5-fluorouracil. Remember 5-fluorouracil and a drug called capecitabine. They are typically known to produce something in hand and foot that has been tested. Even when I was writing NEET PG like exam, that was asked, what do they do? 5-fluorouracil and capecitabine, they can produce hand foot syndrome. Hand foot syndrome. It's nothing but they will become red in color. That's it. Yes. What is the lab monitoring when methotrexate is used? We need to do LFT because methotrexate is hepatotoxic. Which anti-cancer drug inhibits dihydrofolate reductase? It is methotrexate. Remember, when we use methotrexate, dihydrofolate reductase is inhibited. So what is not formed? There is decrease in tetrahydrofolate. What happens if you decrease tetrahydrofolate? There is decrease in formation of thymidine monophosphate. So what happens? There is decrease in DNA synthesis. So this is also been tested. Let me repeat, methotrexate inhibits dihydrofolate reductase. So there is less tetrahydrofolate. Without that, there is less thymidine monophosphate. No thymidine, no DNA synthesis. Radiation recall syndrome is caused by the anthracycline, that is rubicins, donrobicin and doxorubicin. Drug of choice for CML is imatinib. See, anti-cancer drug topic is a very big topic. Many a times what happens is you think that there are so many things to study and you skip the topic and go. But there are certain important things, at least you read this and go. That much is enough. And then if you have studied everything, that is up to your capacity. But there are certain important points. Have you covered that? Please do that. A male patient with stomach cancer also has heart failure. Which drug should be avoided? So that means which is cardiotoxic. I should avoid doxorubicin. Bleomycin, 2 adverse effects are tested. It can cause lung fibrosis and also it can cause flagellate dermatitis. Both have been tested. Can you tell me an antiarrhythmic drug causing lung fibrosis? Can you tell me an antiarrhythmic causing lung fibrosis? The name is amiodarone. Cyclophosphamide, we know it causes hemorrhagic cystitis, 5-fluorouracil hand-foot syndrome, along with another drug by the name capecitabine. So this is a chemo man, which is going to give some important adverse effect. At least remember this. Cisplatin, CC, they cause ototoxicity and nephrotoxicity. Vincristine, Vinca alkalides, VVV, they cause peripheral neuropathy. Bleomycin, busulfan, lung fibrosis. Trastuzumab, robesin, cardiotoxicity. Cyclophosphamide, hemorrhagic cystitis. Hemorrhagic cystitis. Another favorite for examiners is a drug by the name mitomycin C. Can you tell me where it is used in ENT and ophthal? It is used in ENT and ophthal. ENT, it is used to prevent nasal stenosis after surgery and also to prevent laryngotracheal stenosis. Ophthal, it is also used during certain surgeries, strabismus surgery, to prevent adhesions. So this is also been tested repeatedly, mitomycin C. Now certain targeted therapies, not everything you can remember, but epidermal growth factor, yes, pterygium, very good Rutul Shah. Pterygium, we use mitomycin C. The name is cetuximab, which is used in colon cancer, head and neck cancer. HER2/neu, trastuzumab, used for breast cancer. Bevacizumab, I told you it is used in managing diabetic retinopathy, but it is also used in colorectal cancer, targeting vascular endothelial growth factor. See, I am giving the most important ones here. Tyrosine kinase, imatinib, dasatinib, nilotinib. So it is used for this. Imatinib is a drug of choice for CML and GIST. Tyrosine kinase inhibitor for HER2/neu, lapatinib, neratinib, used in breast cancer. So when I wrote my NEET PG, the lapatinib was the question asked. Okay. So that is about the anti-cancer drugs. So until now, what I have finished is GIT pharma, ANS, general pharma, renal, CVS. Then today we finished Autacoids, then antimicrobials, a big topic, endocrine pharma. Then we finished anti-cancer drug. These are the things. So what is remaining is blood pharma, CNS, and respiratory pharma. So those things now I cannot continue because it's already 3 hours. I think now we started by 11:30. It's already 2 o'clock. 2.5 hours have been done. So it's better we'll take one more session and finish it up. So what do you people tell? Even though you request, it's not possible because I won't be able to cover everything if I do it now. Okay, so the remaining will be the blood pharma, then the CNS, and then RS pharma. Only these will be remaining. So what I have covered is the GIT, the ANS, general pharma, Autacoids, renal, CVS, antimicrobial, antimicrobial and endocrine, anti-cancer. Tomorrow time, I think I will update in my Telegram group. Even if I am doing, it will be in the evening only. So it will be after 5 p.m. I will confirm by today evening. After 5 p.m. I will do the session. I think another 1 hour is enough for me. Continuously, I am not able to do this sessions, and it's also difficult for you to concentrate. So my request is, please revise whatever you have studied today, and tomorrow we'll meet up. And all these things what we have discussed, the annotated PDF will be shared in the Telegram group of mine. I'll just show you the link for the Telegram group if you are watching it later. This is the green color. You can scan that, or you can search Dr. Bharat's Pharmacology. You will get it. This is the Instagram. And if you have liked this video, please, you can like it, subscribe to my channel, and share to your friends. It's up to you. Okay, if you find it useful for others also. Thank you all, and thanks for your time. Hope this will help you in excelling your exams. So take care. Thank you.